what we're going to do is we're going to go through maybe some new targets and ways of looking at how to characterize inflammation in people chronically, and I think they're important ways because they lead to more global ways of looking at individuals, and so so that's what I want to try and accomplish tonight in our hour. So well, this might work. I always find this to be kind of humorous. So let me see if I can get this. Let me see if I can get this to work. And if it can, fantastic. It doesn't look like it is. Nope, it's not going to. Okay, so we don't need to worry about those videos anyway. They're kind of for more entertainment. So these are the key things we're trying to manage, right, when we're looking at people. And obviously, the Metabolic Code platform tries to condense all of that together. And the real value is trying to figure out, well, where do I start to get more and more validation that there's shifts going on in individuals. And a few of the markers I want to talk about tonight are to try to really get a handle or a grasp on what's going on with inflammation in general within the arteries, at the mucosal membrane, as well as in areas like the kidneys, which I've talked about before, which you guys have listened to some of my talks. So there's obviously all these different areas. So from oxidative stress and obviously inflammation, hormone balance, stress hormones, glucose and insulin regulation, immune balance, detox capacity, genetics. We're going to really focus on how to look at inflammation. And obviously, I always like to kind of start with this process of understanding of what dictates inflammation is the same thing that dictates every shift in someone's metabolism, meaning that your metabolism is the sum total of all the chemical reactions that drive you towards health or disease. And understanding those disruptors really allow you to unwind the inflammatory chemistry of the individual and rejuvenate the person's health at a cellular level. And this whole issue, of course, is the fact that, which we're going to talk about, is the interface of the gut and inflammation. But this whole issue it's a whole body issue. Once again, even when we make triad discussions of thyroid, adrenal, pancreas, gut, immune, brain, we know that we could call it a gut immune thyroid. We could call it a brain immune heart. So we're somewhat making artificial connections and constructs for the ease of being able to delineate how these relationships work. And obviously this is what we're trying to do, is we're trying to get the process of stress, nutrition and digestion, patterns like cravings, medications, all these different things add up to create where a person lands. Toxins and sleep, these are the things on the macro level that are affecting people all the time, right? Whether they're craving or impulsive, whether they're having sleep problems, stress is at a high, they're getting inundated by toxicity, they're on medications. It's driving this process. And yeah, there's a lot of other things other than this, but these are the key drivers. So this is interesting, and I took this as a quote right out of Rockefeller University Press. So chronic inflammation markedly increases the risk of development of cancer as seen in patients with irritable bowel disease. It's interesting. I had an irritable bowel case in here, actually, an irritable bowel case and a colitis case. And the colitis case happened to be a doc and was talking about the fact that we should be measuring VEGF for that doc. And it was interesting because it came about from reading this quote. And therefore, angiogenesis and VEGF signaling might pose an important link between inflammation and tumor development. However, the mechanisms that lead to cancer and chronic inflammation and the role of angiogenesis and inflammation-associated cancer remains poorly understood. I don't necessarily agree with that. I think that the mechanisms that trigger hypoxia-inducible factor are fairly clear. But what I think that's interesting is that there's these markers like VEGF that we traditionally look at and think that, well, maybe this is a a good factor for endothelial dysfunction, but it's triggered by inflammation, and in early swings in VEGF can be indicative that a highly inflammatory process is coming. And you can get VEGF as a marker really easy. Chronic inflammation leads to upregulation of VEGFR2 in the intraepithelial cells. So when you measure VEGF, it is a marker for mucosal barrier inflammation, and it triggers cancer that is from its genesis of colitis. So it's released at various immune cell sites and then expressed after the initiation of hypoxia-inducible factor 1 alpha. Why that's so important, guys, is that when people are triad 1, they have insulin resistance, they have cortisol elevations, their thyroid's going low, that triggers hypoxia-inducible factor 1 alpha. And the reason it does that is because when you're making more lactic acid within the cell, it needs to survive. So it triggers this hypoxia-inducible factor 1 alpha. And that elevation in that is what ends up driving cancer cells. And so the beginning of it, or the gestation of it, is occurring in this whole issue around insulin resistance, elevated stress, low thyroid hormones, the burning of fuel inefficiently because of poor thyroid hormone content. And so VEGF is really kind of a marker of how efficient your metabolism is becoming and how inflammatory it's becoming at a ground state. So that, to me, this is like one of the better markers that people don't look at enough. So this is another study that shows in digestive diseases, VEGF is a mediator of inflammation and mucosal permeability in patients with collagenous colitis. So VEGF, once again, alters permeability. And I think what you'll find is your people with chronic permeability problems will have slightly elevated VEGF. And that the reason that's important and why you want to work backwards and use this as a marker to be characterized is that it points them in the direction of developing cancer years later. And so this is, to me, we all think of inflammation markers like, and we're going to talk about it soon, myeloperoxidase or OXLDL or C-reactive protein or maybe IL-6 and TNF-alpha, which are good markers. IL-6, TNF-alpha sometimes don't work out quite so well, but, because a lot of times they don't show up until it's really hot, until problems are really big. But VEGF actually comes on pretty early in individuals, and you can use this. And you guys have seen me use these slides before, and this is that whole thing of triggering hypoxia-inducible factor 1 is, cancer cells in a 5.5 molar glucose solution, cancer cells in more concentration of glucose, cancer cells when you add insulin to it. So the reality is the more insulin resistant people become, the more insulin-like growth factor, IGF-1, they start to pump out. The more IGF-1, the more insulin, the less the receptor works, the more you end up here. And this is, to me, just striking, right? When you go from here to here, a lot more red. And so we're really looking at this dynamic balance, right, of what's going on with inflammation, what's going on in the gut, and what's going on in the environment as to what creates our metabolic balance or disturbance. As we age, we're supposed to see these kind of trends. So if you look at this, because inflammation equals immune dysfunction, right? I mean, everybody knows, cancer is an inflammatory process, heart disease is an inflammatory process, diabetes is an inflammatory process, So look at the graph on the left. On the left, you can see that B cells or acquired immunity is basically at a trough right before the age of 60, and that as you get older between the ages of 60 and, theoretically if you made it to 120, your acquired immunity would go up. The purple line shoots up. And then on the other side, you see your natural killer cell activity and T cells going down. Makes sense. Once people get to be age 80 or so, they get a bug. It's a leading cause of death is catching a flu bug, right? So they lose their natural killer cell activity. My argument is that because of all the stressors on immunity, because of the chronic vector problems, whether it's Lyme or any of the other related vectors, that 60 is now moved back to 30. So people are getting sicker and sicker earlier and earlier because of these disruptions in their immune function. And it's not either or. Sometimes you get people with acquired immunity and they're attacking their own tissues, right? You get acquired immunity and you break down your gut. You trigger your T cells, killer cells, to go and attack immune cells, to attack beta cells of the adults of Langerhans. So it isn't an either-or thing. Now, as you go over here as aging years, all of us are reading about IL-6 and TNF-alpha, whether it's related to chronic fatigue or fibromyalgia, obviously, and other chronic illnesses, and depression, for example. But once again, the way this has been traditionally depicted is that IL-6 and TNF-alpha are on the rise when you get into past your 6th decade. Then you start to lose IL-6, which is kind of the balancing act of your immune system. But the point being is because of oxidative burden, environmental burden, genetics, exercise, diet, poor quality drinking water, you name it, right? All the things we always talk about to cause a problem. These shifts have triggered inflammatory signaling earlier and earlier. That's why looking for some of these underlying markers that are easy to get. You can get VEGF from Quest. You can get, it's an easy one. You can measure C3A and C4A from LabCorp and get an immune complement, assay. But the bottom line is that this inflammation process is coming from, I know you guys see this circuit a lot from me because it's so important that you really master the circuit. People get under stress. It could be mechanical stress, a vector stress like a bug, a virus, bacteria. It can be nutrient deficiency. It could be, heavy metal burden. The bottom line is we start to trigger in the bottom right-hand corner this inflammation and immune activation via the intestine. So if you look at this, via the bowel, antigen presentation, antigen-presenting cells triggering systemic inflammation and immune activation. That's why you measure the markers we're going to talk about tonight, like VEGF, and then some others that we're going to get to in just a minute. Obviously, one of the biggest things you can do, and I know I've talked about it a lot, but this kind of gives you a better idea. So if you look at maintenance of immune tolerance, there is this Th2, Th9, and Th17 role for our immune cells. And what we're really trying to do is keep our immune system in a balance. But what happens is that, and how many people do you see now that are having mast cell disorders? I had a girl in today. I mean, she was, she was blotchy and red and histaminic, and she's like, oh yeah, I was having problems with my gut and my belly, but now when I'm training hard, my airway's starting to go. So she's got histaminic, eosinophilic issues, and so when you look, this eosinophilia and mast cell recruitment via Th2 dominance, that's immune activation that's taking place, right? And then you get neutrophil recruitment, which is trying to drive immune activation and immune response. Now, so how do you look at these? Well, you look at monocyte eosinophils, and basophil percents. And you can look at absolute numbers on neutrophils, for example. If your neutrophils are high, you know you're recruiting them, right? That means someone's immune system is being pushed. That's a core immune marker that you should be looking at. Do they have high neutrophils, high normal, or are their neutrophils really low? They've went through the recruitment phase, and now their immune system can't keep up with production. The next piece of that is, mast cells. And look at basophils and eosinophils and monocytes, right? I mean, monocytes and eosinophils will tell you what's going on. And if you're trending high on monocytes, you know you're triggering macrophages, and you know you're inducing things like plaque formation. And that's fine. I mean, you just have to understand that if that's what's going on, why? And a lot of times it's coming from the relationship between the gut, the fact that cortisol triggers leakiness in the gut, that you release more histamine, and those are the key markers that you see. So always, when you think of building a panel to understand inflammation, VEGF shows the ground state inflammation with the gut. I just showed you in colitis and IBD why, and then monocytes, eosinophils, and basophils give you a snapshot, and neutrophils give you a snapshot of how the immune system is behaving and where the heat and the damage is taking place. And of course, histamine does a lot of things. So, the reason I'm so interested in histamine is because I see so many problems with elevated histamine. When I see people that are dermographic and histaminic, you start to see, if you notice here, on the left-hand side, it's 7 o'clock in the inner circle. Endothelial permeability is upregulated in the presence of histamine. So just your gut getting leaky and starting to create mast cell leakage of histamine leads to a systemic effect that creates endothelial permeability changes. Now, why is that so important? When you get endothelial permeability and you add monocytes elevating, and that means that, and maybe their LDL particle size is small, maybe you've looked at that, they've got a small LDL particle, now you've connected the allergic reaction going on in the gut, the endothelial activity in the smooth muscle of the vessel, the vascular endothelial growth factor that's going to be triggering, causing smooth muscle stickiness, and the fact that the monocytes have been activated to trigger the attack. So the monocytes activate the macrophages to trigger this attack. That's just in this one little area at 7 o'clock. Let's look at 10 o'clock. Tachycardia and arrhythmias. Think how many people you're seeing nowadays with arrhythmias and tachycardias and palpitations. Histamine is a big culprit that a lot of people don't take into account for. The obvious of urticaria and flushing and pruritises and skin problems, my gosh, I mean, how many people come in now? 2 people today. One with their dermographia and asthmatic type response, bronchoconstriction. The other with an eczema around both ankles and expressing a lot of allergic symptoms and knowing they have food intolerances. So if you look around this, you could digest this one slide for the whole night. Look, estrogen goes up, in particular estrone goes up in histamine. But what do we do when we see elevated estrone? We just go, oh, we're going to knock that estrone down. You got to shut down why it's elevated, and many times you're going to see those estrogen-dominant women who are candida-like dysbiotic individuals who are producing too much histamine, right? They're red, they're ruddy, they're dermographic. You see how it all starts to tie together? And looking at these kind of global pictures really help you to figure out, well, where is the inflammation coming from and why, right? So, interesting stuff in my opinion. I know we only got an hour. We could talk an hour on the nuances of this one slide. I mean, this is just fascinating stuff. But, once again, diarrhea, constipation, my last case of the day, food allergies, diarrhea, constipation, classic. And of course, we're trying to avoid these kind of things, but the reason I put this up, it isn't to talk about food allergies in kids. It's the fact that once we have this population of early inflamed guts in our children, this next 30 years for cancer, because of the elevated VEGF, the elevated immune system activation that's going on, the elevated hypoxia-inducible factor, the fact that 1 in 2 adults are now diabetic or pre-diabetic, and that it's growing rapidly in children, that they're insulin resistant, all that's driving this chemistry of inflammation. And then this just kind of gets to the development of the immune system. I didn't want to really go over this. You guys know we got to use good beneficial flora to help that. But this is interesting because, look, if you look to the left, what activates your immune system? Microbes, trauma, toxins, mitogens, antigens, cancer. Our innate immunity is triggered by dendritic cells, natural killer cells, neutrophils. Just remember, when the neutrophils are going up, take a look at this slide. The neutrophils go up, it triggers inflammation. It triggers IL-6. It triggers TNF-alpha. And as all that innate immunity is getting upregulated, it goes over and starts to trigger things like immune tolerance issues and cellular immunity and acquired immunity. And these are the things that are taking place in people. It's a mixed bag. It's not one or the other. It's both. The one thing I'm going to point you to, though, as antigen presentation goes up, we drive TGF-beta, which is certainly a big issue as well, right? Because we can start to get into Treg cell shifts, creating more suppressor cell activity, so that we're not able to fight off things like Lyme anymore because of chronic inflammatory signaling that we've built in our immune system that uncouples our ability to fight off vectors. And obviously this is an HLA staining for type 2 diabetics versus controls. I looked at 2 people today with their HLA sequences, and they both had them. One was really good about being gluten-free, the other one wasn't. The one that wasn't good about being gluten-free had gained about 20 pounds and was feeling inflamed and had eczema. The one that was HLA positive and had MTHFR SNPs and was better about gluten but not so good about stress, having a lot of anxiety issues. So both triggering from the gut, kind of a gut immune brain reaction. But in this case, it's very simple. HLA positive type 2 diabetics this is all immunoperoxidases that it's stained with, so this is a very high inflammatory signaling response. And so myeloperoxidase being a source of inflammation, you can get MPO, and you may want to think of, if you look at MPO as a major protein in neutrophils, right? So what did I say? When you get high neutrophils, you're probably going to be triggering myeloperoxidase, but MPO is directly correlated to inflammation and the progression to plaquing of arteries. And remember, it's also a component in monocytes. So when you have real high monocytes, chances are you're going to have high myeloperoxidase, and chances are you're going to be prone to initiate plaquing. It also generates high levels of reactive oxygen species. One of the easiest things you can do is check pH of urine and check pH of saliva. pH will dictate hydrogen ion excessiveness and can be a marker that a simple marker. Yeah, you can look for other markers. I understand that. I'm just trying to give you guys some basic things that you can look at. So monocytes, MPO, neutrophils, percent MEBs, VEGF, all really powerful markers for global inflammation, not just endothelial inflammation, but global inflammation. And myeloperoxidase here, if you look at this, if you look at elevated myeloperoxidase, it increases vascular inflammation. So you can look at VEGF once again. It can, obviously increase your risk of heart disease, increase your risk of insulin resistance and type 2 diabetes. That's why I like myeloperoxidase as a marker, because it's showing kind of the really revved up immune component that is triggering a lot of these progressions of these diseases. This is a 2015 study. This is in overweight people, 84 overweight subjects myeloperoxidase was significantly higher in people with insulin resistance, along with TNF-alpha and IL-6. So this is the Diabetes Metabolism Journal. This is a really interesting study that just came out, and it makes sense, right? People with insulin resistance end up plaquing their arteries more. I mean, I don't know anyone for me that's insulin resistant and have an elevated MPO. It's an immediate aged garlic extract recommendation. I mean, you got to, not that I'm, I haven't really went into any solutions to this, but if you're trying to control VEGF and MPO, aged garlic extract's amazing. 1,200 to 2,400 milligrams a day. Do it in divided doses. There's going to be a new, more detailed clinical strength of aged garlic soon to come out into the physician market. So you guys will be looking forward to something that is going to be very exciting, I think, in the next 6 months with, human studies on the endothelium showing it under imaging that it normalizes the endothelium and reduces vulnerable plaque. So that's pretty interesting. That's Budov's work out of UCLA. And I just put some things down here for MPO for you to look at, what the trending high levels are, what alert high levels are, so, you kind of, I guess that is reversed. That should have been alert high at 471 to 540 and trending high at 470. My bad, guys. And this is kind of that, so please try to remember, if you do, use these numbers, it's flipped. Don't know how that happened. We account for it in our lab test. We're adding MPO right now, so we're VEGF and MPO are being added into the algorithms right now because they're just so strongly medically accepted. So we're going after those. And this is what we already talked about, right? If your VEGF is high and your monocytes are high and your eosinophils are high and your cortisol is high and your estrogen is high and your histamine is high, your epithelial activation is going to become abnormal. You're going to get leaky. Proteins are going to get through. You're going to create an antigen-presenting cell that alters the mucosal barrier, sends a message to the autoreactive T cells and B cells, leading to destruction of the islets of Langerhans, so pancreatic islet inflammation. And then obviously, this particular piece of information is fermentation of complex scars by microfluoroform energy involved in pathogenesis of T1D. For example, if you're not making enough butyrate, you can't keep the mucosal barrier intact. That's why we're big fans of using resistant starch. So if you're not using high maize and you're type 1 and type 2 diabetics or people that you're having trouble retaining that mucosal barrier integrity, give them some resistant starch, 15, 20 grams once or twice a day, and their intestinal cells will never be happy here. I mean, if you want to use chicory root as part of it, or you want to try and, get other forms, but, things like high maize really work well. And the whole reason behind this inflammation piece, you see the small intestine sending a signal via this, in a crosstalk, via the spinal cord to the sympathetic nervous system and triggering inflammation and nociceptor activity. And so we know that, when the gut gets inflamed, you're going to trigger this, and it's going to result in a central nervous system inflammation. So the sympathetic overdrive that occurs, which is directly an innervation of the sinus node, it creates increased sympathetic nervous system, chronic stress, and leads to neuroinflammation, and then leads to elevated resting heart rate and poor recovery heart rate after exercise. And I had someone here today with a 90 resting heart rate. Their thyroid wasn't crazy, but why was their heart rate so high? Tremendous amount of stress. Their wife's going through breast cancer. He's a wreck, but he's been building this stress for a lot of years. And now his resting heart rate's going up. He's getting sympathetic nervous system dominance. His gut's getting leaky. He's reacting to things. That's the stuff you start to see. And, you know, this is so rudimentary, but I just want to keep it in mind. Look, you know, when cortisol is really high, look at it in serum too. You don't have to always do it in a 4-point salivary cortisol. You know you're going to be affecting DHEA at some point, and that's going to shift immunity. Just because you have a low cortisol, though, doesn't mean you can't make it. It might be that your immune system is shutting it down because of trauma or damage. But the point being is, when you see people with chronically high cortisols, you can pretty much suspect that VEGF, beta-2 microglobulin, myeloperoxidase, MEBs, neutrophils can all be at risk. Now, why am I giving you all those? If I have somebody that comes in and their cortisol is high, but their MEBs are normal and their VEGF is normal and their myeloperoxidase is low, I'm probably just thinking of some localized support to get the cortisol to come down. Like, are you under a lot of stress? Do we want to give you some Relora? Do we want to give you an adaptogen? Do we want to give you, you know, exercise techniques or breathing techniques to help you get your stress levels down? You know, what do we need to do to bring that down? I know I've brought this out before, but just remember, when cortisol is high, it does drive all these inflammatory issues. So sex hormones go down, growth hormone goes off, your immune balance alters, your blood pressure goes up because of the sympathetic nervous system dominance and the kind of the syndrome of your blood pressure getting stuck, and of course an increased abdominal fat, visceral fat, and insulin action goes down, all of which are going to lead to all the major things. So if we think of the major things that are caused from inflammation, you know, osteopenia, muscle loss, metabolic syndrome or cardiometabolic risk, Alzheimer's and cognitive decline, immunologic compromise, fractures, you know, memory loss, all these things are a byproduct of, you know, inflammatory processes that are going on. And of course, the cortisol curve being flattened. Why I have this in here? I know you guys have seen this slide from me before. It's IL-6 elevation, guys. Remember that IL-6 that I said really didn't start to go up until you're in your 60s traditionally, you know, as of like 20 years ago? Now we're seeing IL-6 going up and catching it in these conditions in people in their 30s and 20s. People that flattened their cortisol out. They've just overworked, or maybe they got an infection, but post-traumatic stress disorder, IL-6 goes up. And of course, why is it important that if IL-6 is up, is that IL-6 increases the expression of Claudin-2, which basically uncouples the protein structure of the tight junction glycoproteins. So your tight junctions disrupt, and the reason for this is, you know, VEGF is doing that, cortisol is doing that, histamine is doing that, and now at the cellular level, this inflammatory cytokine is inducing Claudin-2, causing these tight junctions to dissolve. And so that's why it's, if all you do is say, I'm going to give you glutamine, and I'm going to give you butyrate, and you don't characterize how bad the inflammatory signaling is, if you don't shut off all that inflammation and reduce the MEB activity and get the VEGF down, get the myeloperoxidase down, get the cortisol managed correctly in a normal diurnal pattern, you never get the person over their food allergies and intolerances, and they continue to have histaminic issues, and it becomes a very cyclic event where they're dealing with their food allergies with you for years. So the reason I'm putting this to, you know, I hope I'm making this argument to fold back on itself so you see the global picture is that a lot of times we end up not looking at things in this kind of relational way. So this is literally tying in the first three triads right now. So this is cortisol and insulin resistance. This is cortisol and immune disruption causing a leaky gut leading to brain, meaning stress, anxiety, all those types of depression, which is associated with this disruption in the gut balance. And this just kind of shows IL-6 mediating the tight junction. So when IL-6 goes up, Claudin 2 goes up, Claudin 2 goes up, the tight junctions unwind. Real, simple. It's coded on a protein, and it triggers PI3K and AKT, and within the cell you get this Claudin exacerbation. And so once again, when you disrupt the cytoskeleton, antigens and vectors appear. So when you see measuring things like zonulin goes up, and we know you get leaky. But zonulin going up, and it is also a sign of infection. But IL-6 and cortisol can also be thought of as, well, what's going on in the immune system of the individual, and is there some sort of infectious process that's going on? And of course, IL-6 directly related to permeability of the gut. Just remember, when cortisol curve is flattened, IL-6 shows up. When cortisol curve is flattened and IL-6 shows up, allergies, histamine, and all the things that histamine brings that I discussed earlier shows up. And of course, there's issues around gut inflammation and serotonin. If that slide didn't, I don't know why that's not showing up. We'll have to go past it. One of the biggies, cholinergic agonists inhibit cytokine synthesis and protect against cytokine-mediated inflammation. Everybody's busy giving glutamine. Everybody's busy giving butyrate. We need to give choline. So whether you want to give phosphatidylcholine or use like NT factor choline powder, or you want to use alpha GPC, stimulate or use those plus huperzine so that your cholinesterase inhibitors are intact, so you can keep your choline on board. When you get enough choline in the brain, you limit the excitatory response. That's why phospholipid therapies are so big now, right? Putting IV phospholipids and oral phospholipids back into people. It's not just about the fact that it regulates the cell membrane. It's the fact that cholinergic function ends up down-regulating cytokine inflammation. And this is just kind of, I don't know, this is kind of just a fun little slide. I mean, but the big thing here is, of course, is that when we get under chronic inflammation, our adiponectin goes down, our TNF-alpha goes up, IL-6 goes up. Remember, this endothelium start to allow for LDL cholesterol to go through. Histamine, myeloperoxidase, VEGF, IL-6 cause that endothelium to become more sieve-like. And of course, as your CRP goes up and your plasminogen activator 1 goes up, and as your ox-LDL goes up, you're plaquing your arteries. And this is why I like aged garlic extract so much, because in humans, it downregulates CRP, upregulates adiponectin, downregulates TNF-alpha and IL-6, reduces oxidized LDL and VLDL, and retards ICAM-1. So when you look at it as an individual agent, it works quite well. And we've kind of been through this. This is just kind of the the risk factors for inflammation, but I really want to get by this slide. Now this is your endothelial cells on the left, right? And this is your endothelial cells 48 hours before a heart attack. And so what makes these endothelial cells get all irregular and excited? It's when the threshold of inflammation occurs that triggers these cells. So these circulating endothelial cells become irregular and multinucleated in an acute MI. Let me go back. On the right, acute MI. On the left, normal. Which kind of cells do you want? The normal ones or the ones that look like they do on the right, right? That's why you limit oxidative damage. That's why you want to look at these inflammatory signals to prevent the left from, in an acute phase reactant situation, going to the right. And of course, this goes down to the, the kidneys as well. When you lose redox, the inflammation from losing redox triggers renal hypertension. You get profibrotic activation and inflammation. So when your urine is acidic, you are in a pro-inflammatory state. And of course, this leads to renal hypertension over time. And these are the things we're trying to neutralize, right? And I know if you guys heard my kidney talk, I went through this already, so I'm not going to burden you a lot with this, but the bottom line is the more that we can neutralize our byproducts of oxidative forces going on in our body, the more we retard the damage that the tissues take on due to that oxidative stress. And, low urine pH, once again, what's it linked to? Accumulation of visceral fat, insulin resistance, methylglyoxal concentration, which is an advanced glycation end product, hypertension, increased intrarenal oxidative stress, and then the upregulation of the renin-angiotensin system. So check your urine pHs and your people that you're using ACEs and ARBs on that have got kind of that insulin-resistant RAA activated system. And I'm telling you, I've got a guy right now. He just sent me his blood pressure numbers. That was one of these guys. I loaded him up with magnesium, changed his diet, gave him some phospholipids, and his blood pressure changed. He went from 145 over 95 to 125 over 75 in a matter of about 8 weeks. I mean, so this is really important. Urinary pH, once again, it's it's an issue because the lower the urine pH, the more you see with chronic kidney disease, and there's the next marker you should be looking at. You should be looking at uric acid, because elevated uric acid really is a sign that you're under high oxidative stress. And so that is, is really something to see. Then the next thing I want you to look for, this is a 10-year observational study with 350 participants looking at this data, altered 8-OHDG. And so the 8-OHDG, 8-hydroxydeoxyguanosine, is related to when pH in urine is low, you have more oxidative damage, and it alters your pulse wave velocity. Well, what's that mean? It means your vessel dynamics change. Your vessels aren't as pliable. So inflammation, triggering oxidative damage, distilling down to urinary pH, leading to markers for methylation damage like 8-OHDG and markers for oxidative damage like uric acid. And I know you guys are seeing more people with high normal uric acids because I'm seeing them left and right. And then, of course, alkalinization being important. I got to tell you guys, I love fulvic acid. All fulvic acids aren't the same. If you guys get interested in fulvic acid, we've got a couple that we really like because it really helps with balancing pH of the urine. And of course, magnesium citrate, potassium citrate. Actually, maglysonate will do it too. Lemon juice water, half a lemon in water. But here's the thing. Independent correlation of the urine pH and progression of uric acid in serum. So the higher your uric acid in serum goes, the more you know you're taking on oxidative damage in your kidneys, triggering systemic inflammation because the hydroxyguanosine is going up. So it's predictive, right, for renovascular disease. And I know when I did my kidney talk, I ended up here. I don't want to go too much into this because I'm trying to pull together all of these markers for inflammation, but I just want you to look at the correlation with deoxyguanosine, that you know that deoxyguanosine is going to be problematic, and you can pick up deoxyguanosine markers. They're not that hard to pick up. A lot of different labs are using them now. So the conclusion is that in this particular case, in which I really wanted you guys to think through this, Over a decade of improvements in blood glucose, lipids, and blood pressure occurred with drug therapy, but there were no improvements in obesity, acidosis, fatty liver, hyperuricemia, and the advancement of renovascular disease continued. So just because we pull your lipids down with a drug, like a statin, or your blood glucose gets better because of metformin, and your blood pressure goes down because you're an ACE or an ARB, if you don't manage the oxidative forces and the damages, the metabolomic consequences of this, they still progress in their disease. I know you guys have seen that. And another interesting marker, beta-2 microglobulin, interesting for the kidneys as well. So a serum beta-2 microglobulin tells you if you've got a leaky blood-brain barrier, and it's a marker for inflammation. So I see a 2 or higher beta-2 microglobulin. That means you're trending towards systemic inflammation that's beginning to affect the blood-brain barrier. And then, of course, urinary beta-2 microglobulin is showing that there's inflammation once again, or some kind of tubular injury. So you guys are more familiar with that. But here's the thing: beta-2 microglobulin is released by T cells, T and B cell lymphocytes, all right? So this is telling you, if you're tracking beta-2 microglobulin, if it's showing up, you have a very active immune system. And so where does it show up? In cancers, infections, autoimmunity, renal function, as we just discussed, vascular inflammation, and coronary artery disease. Trying to show you guys some end targets that are really important, that'll show you how far along the inflammatory process is taking a person towards pending disease. In this particular study, this was beta-2 microglobulin on irritable bowel. So the mean beta-2 microglobulin was higher in people with ulcerative colitis and Crohn's versus controls. This would be a good way for you to look at. If their beta-2 microglobulin is high and you're initiating therapies like Interrogam, I don't know if you guys are familiar with Interrogam. It used to be IgG powder from Zymogen, but now it got released as a medical food in the medical market. It's an Interrogam. If you guys aren't using it, look up Interrogam because it definitely downregulates inflammation in the gut. So beta-2 microglobulin, it even shows up in IBD, but it's interesting because when beta-2 microglobulin goes up, your blood-brain barrier gets leakier. So do people with irritable bowel also have emotional distress, end up with panic, anxiety, neuroinflammation? Yes. All right? So beta-2 microglobulin, really easy. Now, if you look here in urine, it's less than 0.23. If you look in serum, less than 2.51. I always say trending high over 2. High is above 2.51. And the other thing about beta-2 microglobulin, guys, I can tell you right now, if that number is over 2.5, you definitely have probably some kind of mercury or metal toxicity. So this is a great marker for metal toxicity, which also obviously triggers inflammatory signaling. Summary of markers that are readily available that you can look at for inflammation. I know I want to keep these talks in under an hour or so, and I know I went kind of quick, but these are things that you can get easily, right? You can get MPO, you can get percent monocyte eosinophils and basophils. Please add neutrophils as well. Urinary and salivary pH, VEGF. I had a couple misspellings here. That's beta-2 alphanumeric microglobulin. IL-6, cortisol, serum, hair, salivary, however you can get it. Red blood cell magnesium, super important to find out if someone is acidic or not. Look at their red blood cell mag. It'll tell you how far away you are from really getting to alkalinize them. And then the 8-hydroxydeoxyguanosine. I hope I tied these together in a new light for you and gave you a little bit of insight as to maybe some new ways to evaluate the people that are coming into you every day. Most of these markers, in fact, all of these markers are being incorporated in version 2 of our Metabolic Code platform because we've done enough research on them now where we feel pretty comfortable that they're going to lead you to correct conclusions. So I will take questions.
Thanks, Jim. We do have some questions ready. The first one is, what are the best forms of resistant starch, and can you share brand names?
Yeah, I mean, I love getting people to eat cold potatoes like Laura will do in diet. Like, and she's got resistant starch talk, I think, on our website, right, Libby? I'm pretty sure she has a talk about resistant starches on our site. So brand name Jaime's is probably the most famous resistant starch. If you're going to eat resistant starch, green bananas and cold potatoes. You know, green bananas and cold potatoes are really good. So those are ways to get them from food. But when you do resistant starch, you know, non-GMO, made from corn, resistant starch, about 20 grams. That data, I mean, please look up the data on resistant starch in diabetics and how it altered gastric hormones when they gave it to them. It changes the microbiome and gets your ghrelin and leptin and GLP-1 signaling aligned. So yeah, H-I-M-A-I-Z-E. Yeah, I can give brand names all day long because we're not in CME.
What lab tests for beta-2 microglobulin?
It's beta-2 microglobulin, and you can get that from LabCorp or Quest. And you can get VEGF from Quest. I didn't go into all the we'll get Dr. Heyman to lecture on C3A and C4A. I didn't talk about TGF beta-1 tonight, which is also valuable for showing chronic inflammation and an upswing in immune response. There's just, that's another good marker. But yeah, those are, LabCorp and Quest markers.
You briefly mentioned Candida. How to do a workup on a patient to diagnose Candida?
Next to impossible with a lab test, really, because people can have IgG, IgA, and IgM Candida markers. Look, if they stick their tongue out and their tongue is coated white and they're bloated and they have food allergies and they're complaining of having sinus problems, you got a pretty strong reason to think that they have Candida. I mean, you could do a CDSA if you want to check out if they've got Candida in their stool. I mean, you could do that too. But I mean, we don't that often. I mean, I don't. In our clinic, we go by a questionnaire, stick out your tongue, and if your monocytes are elevated and you're histaminic and you've got a lot of symptoms related to gut dysbiosis. Now, would we order like a SIBO breath test on somebody if it sounded like SIBO? Sure, but just as an initial kind of program on somebody, unless we really suspect SIBO, we're going to try and clean up their Candida. Because look, Candida just grows because your immune system gets weak. That's the reason it grows. It's kind of like when mold grows on a plant, right? Whenever you see a plant that has mold on it, what for fungus? What's the reason? Ask the botanist. They'll say, oh yeah, their immune system's stressed. We're no different. When our immune system gets stressed, we grow fungus.
Dose phospholipid to decrease blood pressure?
Well, it doesn't alone. Like we did magnesium and aged garlic extract and theanine, and then we gave him the phospholipids to kick in his acetylcholine to allow for his heart rate variability and in recapturing his vagal tone. So getting the phospholipids back helped to create more cholinergic drive, which helps with releasing growth hormone, but also improving how the brain is sending out communication centrally. So don't use a phospholipid just for blood pressure. You use choline derivatives to improve the tonicity of the nervous system, and then you use things in conjunction like theanine, magnesium, aged garlic, and you're going to get blood pressures to come down really well.
You mentioned fulvic acid. How do you use to balance pH?
Well, I use fulvic acid because it's a mineral. It's an ash mineral, right? So I just put people on it. If it's a powder, it's in capsule form, it's 300 milligrams, 1 or 2 capsules twice a day. I'm experimenting with one right now that's a very purified fulvic acid. There's 2 of them. One is pure fulvic acid, and one that still has other minerals in it. So I am playing with it right now, and it's like a 1/16 of a teaspoon scoop, and it turns the water black, and you drink it. And so far, I've been pretty happy. My pH is never really a problem, but I'm seeing changes in my urine pH, which I tend to run a little acidic that way, and I am seeing a positive upswing. I'm playing with it, right now to give you guys like what brand of all fulvic acids aren't the same. So what brand is the one? And there's a guy that was an ex-NFL player that hooked up with a bunch of research scientists. They started giving this stuff to ex-NFL guys. They started feeling a lot better, and they started looking at it. And here the scientists are purifying your fulvic acid pretty significantly. So we're like the next talk I give, I'll give you guys the brand name of that after I've researched it enough.
Okay. An infectious disease doc suggested taking vitamin C for UTIs to increase the acidity of the urine. Would you recommend increasing the acidity of the urine to reduce the frequent?
That's an infection. That's different. So yes.
Okay. Does taking potassium citrate with meals interfere with digestion?
I don't think so. No, not at all. Because potassium citrate isn't alkalinizing like taking a Tums. It's because of the because of the mineral content. So no, it doesn't. It won't neutralize your stomach acid.
Dose of phospholipid to decrease vagal tone as adjunct. To increase vagal tone.
Right. That's it. That was that slide that I showed you that it inhibits the inflammatory cytokines and rebalances the neuroinflammation. You want to get cholinergic agonists or build acetylcholine. That's exactly it. You want to. That's what you want. Now, yeah, you could use other things like we use that neuromedulla. I know Dr. Heyman talks about it. I've used it about 20 years. I love it. It's from Professional Health Products. That product does a great job of resetting vagal tone. So for my PTSD cases and Lyme cases, Andy uses it on Lyme. I do it more on my stress cases, my PTSD cases. Neuromedulla is really good at resetting vagal tone. So the problem is nobody's eating egg yolks anymore, right? So nobody's getting dietary choline, and you need dietary choline for your brain. That's why so many people need, phospholipid replacement when we're dealing with them when they're chronically ill, because their membranes are so beat up. So give some phospholipids. Either give choline, like phoscholine, or you can have people eat eggs, or you can. I like. The one that's proven to improve mitochondrial function is NT factor choline. So that's kind of a cool, they got studies on it, man. I mean, they're serious about their phosphocholine research. So if you look up NT factor, that will give you some really neat insights into that product. And I just use the acetylcholine, the phosphatidylcholine one. I don't use all their other stuff.
Can you give any doses on that?
Well, I mean, if you're using it in a powder, you can do, a teaspoon a day. Just like when I use alpha GPC, I tell people eat as much as you can afford. It's like take a half a teaspoon a day if you can afford it, because most people are sorely deficient in dietary choline, and that leads to all kinds of neurotransmitter imbalances and the inability of the nervous system to fire correctly, which triggers all those problems with vagal tonicity and So yeah, you can use that if you want to dose in the chewable tablet form. Typically, it's at least 500 milligrams twice a day. If you're going to use phosphatidylcholine liquid, 70% phosphatidylcholine, typically teaspoon twice a day, and you're getting a big whacking dose of that choline. That NT factor it's a special kind of the way they develop it for delivery. they've proven that it upregulates mitochondria. I mean, it's really exciting stuff. So.
What about Shilajit for increasing pH?
Well, Shilajit's fulvic acid. So, yes. It's just a Western name for an Ayurvedic herb.
Okay,
That's
and
good.
it looks like the questions are winding down. We do have one hand up from Don, and let me unmute Don so he can ask his question.
Hi, Don.
Looks like he's muted on his end, so let's see if he can pull up the audio here while we're waiting. Another question came through. My client vomited from acetyl L-carnitine. She was an alcoholic. Is she missing phosphocholine?
Ah, yes. Alcoholics are really, their membranes are horrible, right? Because they're dissolving them with all the alcohol. So, yeah, she needs phosphatidylcholine. And maybe just try using straight carnitine instead of the acetyl group. See if that helps too. And do a smaller dose. I don't know how much you gave, but doing less, like start at 250. But if she vomited, yeah, start with some phospholipids.
I'm still seeing Don muted on his end, so if he can type in the chat or unmute, we'll take that question. It looks like actually there's another hand up, so I'll go ahead on to that one.
Okay.
From Casey.
Hi, if you have a patient that has symptoms maybe of both SIBO and Candida, but the comprehensive digestive stool analysis says that there are no yeast, but a urine test, organic acid, might read that diarabinol is elevated.
Yep.
Okay, so are you thinking, I mean, I know SIBO and yeast can sometimes, work at the same time.
Right.
Where do you start with that in determining what is the driver?
Well, I don't know. They're probably both driving it right now, right? I mean, more than likely they're both set up shop, and it's a problem. So, I mean, what we do is we go after both at the same time. Like, I just had a bad case. I mean, she's been dealing with her SIBO for I think 6 months before we got to her 2 months ago. And we ended up giving her Alenia because we did Vivanex on her. Are you familiar with Vivanex?
I'm not.
Well, Vivanex is like a medical food that they drink, and they're supposed to be on a low-calorie diet, and basically you're starving the bad bugs out. I mean, the stuff's horrible. Try to avoid having to use it. We had to use that on her. And even after she did that, she was still breathing positive. So then we just did 14 days of Alenia on her while she's been on Nystat.
Mm.
So we had to do both. It wasn't one or the other. All of them are kind of nuances that you have to manage, right? If you're going to do it naturally, then you're thinking of things like olive leaf, berberine, and cat's claw, right?
Mm-hmm.
And hit her with that kind of stuff, or Oregon grape, So in terms of the antimicrobials that you'd use to kind of get a broad spectrum, or grapefruit seed extract tests really well most of the time on a wide variety of bugs. So you kind of got to go after a couple of those and probably drive down both. I mean, I'm like you. I don't quite understand how I get a negative on a yeast, but they have symptoms and it shows up on their urine as an intermediate,
Yeah, and I'm not sure in terms of the symptoms if I can say fairly that this isn't a severe case. Diet is really great, and it's just sometimes, it may just be that the gut bacteria is just not in the right balance to deal with emotional stressors at times,
Yep.
And at that point, then there's an exacerbation of a microbe or a fungus that kind of causes the problem. So thank you for your thoughts on that.
Okay.
I've Been using silver hydrosol mixed with distilled aloe vera to treat candida and SIBO with very good results. Nystatin, sorry for my pronunciation, ketoconazole, and etc. with herbal antifungals all failed to eliminate the candida. Stool negative because candida infection is in the small bowel. Oh, okay. So I don't think there's a question with that, but just sharing that.
Yeah, no, I told you found works. It's great. I haven't had to resort to that to get results, but if that's what's working for you, fantastic that you figured it out. Good, terrific.
Okay, I think we have addressed everyone's questions. I want to thank everyone for being here. Thank you so much, Jim. Also, reminder that we do have our next webinar, education webinar this Thursday, January 14th with Laura LaValle, registered dietitian and nutritionist. The topic is diet, focus on thyroid, food, and nutrient strategies for optimal thyroid function. And you can register at metaboliccode.com/events. And also for those of you who are Air Support subscribers, we hope to see you at the case review tomorrow at 8 p.m. Eastern. Looks like we did have one other question come in with some thank yous. My client has elevated amino acid, but her BUN and creatinine are normal. Her doctors don't believe that she has kidney disease. What should they test for confirmation that she has kidney disease?
Well, I mean, are they looking at her GFR, and are they looking at a global picture of her kidneys? I mean, there's new markers like what I showed you here that could tell you that there could be some risk for kidney disease. So I just think, I mean, if it's the doctors just going by their most conservative CKD, it's what's her creatinine and what's her GFR, and then they stage it. So I mean, that's the traditional way. Then you can look at urinary pH, uric acid. You can look at other things that damage the kidneys, like the oxyguanosine. We looked at things like in the talk tonight. We looked at things like beta-2 microglobulin or urinary beta-2 microglobulin. So you want to expand the look at the other markers to see. Now, does she have full-blown kidney disease, or are her kidneys just inflamed? Meaning that their kidneys are, getting damaged due to high oxidative stress, but she doesn't have CKD yet, right? So that's what you're trying to characterize. It isn't that she has a disease now or not, but is she on her way to having a disease?
Okay, thank you so much again, Jim, and all those who attended. Appreciate you being here. I will post the recording to our blog, metaboliccode.com/blog, within the next 24 to 48 hours. Thanks so much. Have a great night.
Thanks a lot.